Lovely. Well, hi everyone. Thank you for taking the time to join us for this week's and our last of the year Cure Cancer Lunch and Learn. I'm Nikki Kinloch. I'm the CEO of Cure Cancer, and it's a pleasure to have you here today. This session we'll be talking to Dr. Kellie Mouchemore, who's based at the Olivia Newton-John Cancer Research Institute in Melbourne. And Dr. Mouchemore will be discussing her research on triple negative breast cancer, or TNBC as it's known, which is a particularly challenging type of breast cancer. So we will spend about 45 minutes talking about the work that Kellie is doing. If you do have a question, and I have some already come through, please pop them into the chat box. You can see the chat at the bottom of your screen, and then I will weave them into the conversation as I talk to Kellie. So Kellie, welcome to our Lunch and Learn.
Thanks for having me, Nikki. And yeah, thank you to Cure Cancer and all of your donors for generously supporting the research that I'll be talking about today.
Yeah, it's great to have them here. For those of you that are on the call that may not know you, can we start before we talk about the research? Talk about a bit about yourself and how did you end up where you are today?
Yeah, so I'm currently based at the Olivia Newton-John Cancer Research Institute in Melbourne, but I'm actually from regional Western Australia, and I started my science career actually working in a lab in Perth doing immunology research, so looking at the immune system. But I was always really more interested in cancer, particularly breast cancer, just because it's so incredibly common in Australia, and we all know someone who has been affected by breast cancer. So in 2014, I moved from Perth to Melbourne to start my PhD at the Peter Mac Cancer Centre. And I was looking at understanding how the immune system is involved in breast cancer spreading to other organs, which is known as metastasis.
Lovely. So we just touched on the words triple negative breast cancer. So I think the first place to start with is, what is triple negative breast cancer? And then secondly, how is that different to other breast cancers?
Yeah, so triple negative breast cancer is a subtype of breast cancer, and it makes up about 10 to 15% of all diagnoses. And it's actually called triple negative because it's missing the three main features that we find on other types of breast cancer cells. And these are features that respond to hormones such as estrogen. So because they're missing these features, it means that we can't use any of the targeted therapies we have in the clinic that work for those other patients who have hormone receptors on their cancer. And triple negative is usually quite aggressive disease, and it's likely to unfortunately spread to other sites in the body. And because we don't have a lot of targeted treatments for triple negative, for a really long time, these patients have been restricted to having chemotherapy. So it was actually really exciting in 2022 when immunotherapy came onto the scene and was approved in Australia for triple negative patients. But even though that's an exciting development, it only works well in about 50% of patients, and we don't really know why.
So we'll have a question that came in earlier when we sent out our EDM about this session in regards to why is the development of treatment for triple negative in the questioner's perspective, behind other treatments for other types of breast cancer?
Yeah, that's a tricky question. It because the incidence of triple negative breast cancer is only 10 to 15% of all breast cancer patients, it can make it challenging to get enough patient samples to get a picture of what is going on. And also, triple negative has sort of a high degree of diversity. So even when we put several patients' tumors side by side, they can be quite radically different between patients. So I think that's one of the main reasons that it's been, behind in terms of finding new treatments.
Okay, thank you. I have another question here about the likelihood of getting triple negative versus non-triple negative breast cancer. And is there genetically a persuasion of people that will get triple negative, or is it just, as far as we know, luck of the draw at the moment?
Yeah, so I would say it's a little bit of both, because if you have an inherited mutation, so you would have heard about the BRCA1 and BRCA2 genes, some gene mutations like that can be more so associated with developing triple negative breast cancer. But there are a lot of patients who don't have any family history or any inherited mutations, and we just still don't know why they'll develop triple negative breast cancer.
Okay, thank you. So you've come into this area of research, a subtype of breast cancer where it is quite aggressive, it does metastasize, treatment options have been limited. So could you explain to our guests today, with the money that you're receiving from Cure Cancer, what's your project and what are you looking to help solve?
Yeah, so my project is looking into samples from triple negative breast cancer patients who have received immunotherapy as part of a national clinical trial. And we're looking at these samples that were taken before the patients had immunotherapy. And we're trying to find out what are the features that are common to the patients who had either a poor or a good immunotherapy response. So we're trying to work towards a sort of simple diagnostic test where we could predict which patients will benefit and which patients won't, because immunotherapy can be associated with some pretty debilitating side effects. So we want to spare those patients who, from their biopsy, look like they won't have a good response from having to go through this treatment for little benefit. And then we're also looking to try and develop new combination therapies that could convert the patients who are unlikely to have a good response. We could then treat them in combination with something else so that they'll become a treatment responder.
That makes sense. So for those that aren't aware, I mean, traditionally in the past, it's been chemotherapy that or removal and then chemotherapy. So immunotherapy in scientific terms is quite new. Could you explain a bit more about that and what treatment the patients get that you're using the samples from?
Yeah, so immunotherapy is essentially using the body's own immune system to recognize and destroy cancer. And unfortunately, as tumors grow, our immune system can kind of get shut off. So the cancer killing immune cells that we have, which are called T cells, they can become sort of blindfolded and put to sleep and by the cancer. And we call this T cell exhaustion. And immunotherapy's job is to kind of reinvigorate these exhausted T cells so that they can start to kill the tumor cells again. It's kind of like releasing the brake that cancer's putting on your immune system and at the same time, like pushing the accelerator. And immunotherapy has been really good for triple negative breast cancer because it's not so much a targeted therapy. It doesn't need the proteins that we find on the other types of breast cancers. And in fact, it actually works better in triple negative compared to other types of breast cancer because triple negative, there's just something about it where we actually find more sleeping T cells compared to other breast cancer types where there might be just no T cells there at all.
Yeah, that's really interesting. So, when we talk about side effects, we're used to hearing side effects of chemotherapy. So you're saying that there are also harmful side effects to immunotherapy for some patients as well?
Yeah, like I just mentioned, what the immunotherapy is doing is it's releasing the brake on our immune system. So one of the potential side effects can be autoimmunity, so developing things like hepatitis in the liver or arthritis in the joints, just because our immune system is being sent into overdrive to try and eradicate the cancer.
That makes sense. So you're looking at responsiveness to this treatment to essentially stop patients from having this type of treatment if it's not effective from them. And then you mentioned another word, well, two words, combination treatment. So can you describe what combination treatments are?
Yeah, so to put it really simply, it would just be adding another treatment alongside the chemotherapy and immunotherapy. And we don't just want to combine sort of any old therapy with the immunotherapy. We want it to be a logical combination. So what we'll do is we'll look in the patient samples to see in the immunotherapy non-responders what sort of cells or genes are popping up, and we want to know if those are responsible for the resistance to treatment. And then we can look at those cells and then look into the literature and see what potential drugs could be added as a really logical combination therapy to dampen down those cells that are causing the therapy resistance.
And would that be looking at combination therapy for the same therapy for lots of different people, or does the therapy change per person as well? What level are you exploring there?
Yeah, so it's entirely possible that we might need to come up with a sort of personalized medicine strategy because, as I mentioned earlier, like uh, patient tumors can be like quite different patient to patient. So a combination that will work for one patient might not work for the other. So we do want to try and come up with multiple sort of combination options for sure.
Yeah, lovely. Thank you. So a question here about biomarkers, and we're going to talk, sorry, bell's ringing here. We're going to start talking about biomarkers. Could you explain what those are?
Yeah, so just to put biomarkers into perspective, it's currently only around 50% of triple negative patients who have a good response to immunotherapy. So when a patient is treated at the moment, we don't have any indicators or biomarkers that the treatment will work. So we're taking a little bit of a gamble about whether the treatment will help the patient or not. So biomarkers are actually just sort of signs we can look for in the tumor biopsies or in patient blood samples that we know correlate with either a good response to immunotherapy or with no response to immunotherapy. And one biomarker that has been used in the past that you might have heard of is called PDL1, and it's a protein that we find in the tumor samples. And that was a really good biomarker for predicting immunotherapy response in patients with advanced triple negative breast cancer, so in the metastatic setting. But it hasn't been a very good predictor for early TNBC patients who are getting their treatment before their tumours are removed.
Sorry, we've got some technical issues. I seem to have lost my camera. No, absolutely, that makes a lot of sense. So, from your perspective, what is the most challenging piece that you experiencing? That's probably a broad brush, with your research at the moment.
Yeah, so as I sort of keep saying, each patient with triple negative breast cancer can be quite different from the other. And so we need to look at as many patient samples as we can. But because triple negative only makes up 10 to 15% of all breast cancer patients, it's really challenging to get enough samples from these patients. So we're really reliant on these women who, are receiving this terrible news about having triple negative breast cancer and who have this burden of going through their treatment. We're really reliant on their generosity to give us consent to use their samples, because without their samples, we're not going to learn anything new about triple negative breast cancer.
Yeah, no, that makes sense. So I do actually have a question around this in regards to providing samples too. So you've almost actually answered it about the importance if you are going through a cell biopsy and you're asked if you can share your sample for medical research. And in fact, that's exactly what you rely on.
Yeah, definitely. And we are just so incredibly grateful when people do give consent for their tissue to be used for research, because at the moment we're trying really hard to get enough patient numbers so that if we find some biomarkers, we can be confident that they're applicable to triple negative breast cancer in general. So if we don't have a large sample size, we're not going to have that confidence.
Yeah, makes sense. Thank you, Kelly. I'm just going to pause there, and we had a couple of new guests. I'd like to welcome you to this afternoon's Lunch and Learn with Dr. Kellie Mouchemore, who's based at the Olivia Newton-John Cancer Research Institute in Melbourne. We're talking about her work on triple negative breast cancer, which is a particularly challenging type of breast cancer as well. If you do have any questions, I've had a couple more come through, please pop them into the box at the bottom there, and I will weave those into the conversation. Kelly, a couple that have come in from the audience. One is about why is triple negative breast cancer more aggressive in younger women?
Yeah, so I would say that triple negative breast cancer is generally aggressive, no matter the age of diagnosis, but it's more so that I would say if there's breast cancer in a younger woman, it's more likely to be triple negative. One reason that it might be more aggressive in younger women is that it could be women who have inherited a mutation, so the BRCA genes, and this could be kind of like a little bit of a ticking time bomb and can lead to very aggressive disease early. But another reason could be that younger women aren't eligible for mammographic screening. And so we're kind of reliant on them to self-diagnose. And so that could then mean that they're being diagnosed later when the cancer is at more of an advanced stage. But I would say there's also just a lot that we still don't know about breast cancer in young women generally.
Yeah. And it's interesting, I've got a couple other questions in relation to that. One about the BRCA genes. The question here is, are there more genes out there that have yet to be discovered that could actually lead or say that you have a family history, a genetic history of cancer?
Well, I'm not 100% sure, but aside from the BRCA genes, there are a few other known genes that can really increase your risk of breast cancer. And I would say that people with family history have probably had some sort of genetic screening to look for those other genes as well. And they would probably be working with their clinician to have sort of more regular screening in terms of mammograms and ultrasounds if they are determined to be at a higher risk.
Yeah, lovely. Thank you. And on the back of that, there's a question about how is triple negative breast cancer detective and how can you get a screen if you're under the age of 50? And I presume that would be based on your family history and your consultation with your GP as well.
Yeah, and also, mammograms are generally done in women over the age of 50, and this is actually for a very good reason, and that is that younger women tend to have denser breast tissue, so mammograms might struggle to pick up small cancers within younger women's dense breast tissue. So, as you mentioned, women with a family history who are younger are probably having more routine screening via processes such as ultrasounds, which are more effective at picking up cancer in younger women. But I would also just say to everyone that being breast aware is the best possible screening method for younger women. So just regularly checking yourself for abnormal changes and following up any concerns that you have with your GP. And when breast cancer is detected early, generally treatments are more successful and the risk of the cancer coming back is really reduced.
Yeah, thank you. It's a very important message. In regards to your working with patients and samples, do you have any collaborations? Are you working with other units across Australia or internationally on your work?
Sorry about the hospital announcement. That segues nicely into your question. Um, so yeah, the Olivia Newton-John Cancer Research Centre, we're located within the Austin Health Precinct in Heidelberg, and so we have some excellent collaborations with medical oncologists here to be able to get samples from patients. So as they come into the clinic, and we find out they're triple negative and that they're going to receive immunotherapy, we ask them if they're happy for us to use their tissues. But we also do have wider collaborations than that. We're also working with clinical trial samples that come from all around Australia. And we also have some really important collaborations with medical oncologists in Perth. Oh, I would definitely say that some of the interactions that I have with our consumer advocates and also people who have experienced breast cancer. So um, we rely on talking to people who have had breast cancer to really keep our research relevant and to hear like what they think is important and what will actually really benefit patients. So I really enjoy and value the interactions that I've had with people with a lived experience of breast cancer. Yeah, I definitely think it's the new way forward, and the progress that's happened in the last 2 years is crazy. So um, it's only just been approved around 2 years ago for use in Australia, and it's already having such a positive impact. So I think that most patients who are diagnosed with triple negative now would be considered for immunotherapy. And the one that's currently approved in Australia is called pembrolizumab. Um, and that's just one type of immunotherapy. So my project is also looking at a slightly different type of immunotherapy. So there are other types out there that are yet to be approved for use in Australia, but I think potentially will end up being approved eventually, just once we have the evidence that they're going to be helpful as well.
A quick question about your hopes for the future. What are you looking? Obviously, you're doing some incredible work now. Where are you hoping this will take your research, and then what's next after that?
Yeah, so if you just think about my project, I'm really hopeful that we will come up with some better biomarkers to give us a yes or no answer about whether the patient should have immunotherapy or not. So rather than just sort of rolling the dice at the moment. And then I also hope that we can take immunotherapy, which has just been such a game changer for some patients, and just make it much more like helpful for greater numbers of patients. But, being careful that we're not giving the patients this therapy unnecessarily because we don't want them to experience the side effects for little to no benefit. And triple negative patients have just had such limited treatment options for such a long time. So if we can take something that's currently approved and just make it even more effective, I think that would be really amazing. And in terms of my general hopes for the future for breast cancer, I just hope that we'll get to a point where one day we're not seeing any deaths from breast cancer, because we've got such effective treatment options that can help to really manage and better manage their disease.
Yeah, lovely. Thank you. I mean, that would be a wonderful world if we got to that point, wouldn't it? Thank you. A couple other questions that have come in here about the use of your discoveries and whether you can move it over what you've discovered to other cancer types. Is there any translation involved there?
Yeah, definitely. And even for my project, we'll look at other types of cancer where immunotherapy has been more effective. So lung and melanoma, we'll definitely look to see if that can help guide us in our biomarker search. But we're also interested in how there's some similarities between breast cancer and pancreatic cancer. So we're hopeful that our findings in breast cancer might help us extend into looking at pancreatic cancer patient samples because they have such a poor survival rate and very, very limited treatment options. So yeah, and also in terms of immunotherapy, it's not that effective in pancreatic cancer either. So that's something it has in common with breast. And yeah, we're definitely interested in seeing if our biomarkers work across multiple cancer types.
I think I mean that would be fantastic. It's interesting to learn there are some similarities. You wouldn't think that given the different parts of the body, would you? But and the last numbers I saw was a 5-year survival rate of 8% on pancreatic cancer, which is unfortunately pretty low. So any work that you can do there would be incredible as well. A question about your day to day. You're in the lab, but you're also associated with the hospital too. So I know there's no such thing as a typical day, but could you give the audience some understanding of what your weeks look like?
Yeah, I just mentioned before that it's a real mix of being in the lab and also just being in the office doing sort of administrative things. But some things I didn't mention, we try to meet with our collaborating clinicians as much as possible, especially while we're looking for new patient samples all the time. Um, we have a lot of seminars, so to keep us up with the other research that's happening, not just within our institute, but also within Melbourne and also across Australia. We have people come and speak. And then I also spend some time with other people in my team, so supervising and mentoring students, and yeah, also applying for funding, which we spend a lot of our time doing. We spend a lot of time away from the research and yeah, writing funding applications to make sure that we can keep our research going and also to keep us employed.
Yeah, look, that's a nice segue because that was actually my next question. And I know there's a lot of our audience have supported us for a long time, but those that are new to us would be surprised to understand that most researchers in Australia are not paid long term. They have one project from one year to a next, or if you're lucky, you can get a 3 or 5 year project. But you have to continually source new funding to essentially keep yourself employed.
Yeah, that's very true. Most researchers will be on 1-year contracts, even if we have a 3-year funded project. Nothing is ever certain, so we're constantly applying for more funding, and it's really difficult to get funding as an early career researcher. So if we didn't have programs like Cure Cancer, who are sort of willing to take a chance on the younger generation of scientists, I think we would be in a really tough situation for sure.
Absolutely. And I mean, this is why the kind donors that we have here on here today, their money is so crucial because I think last count it was less than 5% early career research applicants were funded as well. So as we can see, you're doing incredible work, and it's that type of innovation that we want to be able to fund as well. A question here about whether your work involves blood plasma as part of the treatment options.
So at the moment, no. We are just looking at the biopsies that are taken from the tumors at the time of diagnosis. But I think that it would be incredible if we could find something in the tumor that we could then develop into a blood test. So, because obviously that's much less invasive and it's something that can be easily checked, throughout a patient's treatment when they're regularly having blood taken. So, we do have some banks of patient blood and plasma stored. So I'm hopeful that as the project progresses and we find these biomarkers, we can then go and check if they also exist in the blood of patients.
Yeah, lovely. Thank you. What motivates you? It's one, it's a hard topic to be dealing with. Two, as we've discussed, your funding goes from year to year, which is tough to deal with anyway. But what keeps you going? You work odd hours, long hours. What keeps you doing this research?
Yeah, I think I just see breast cancer as such an important and hard issue to tackle. And I worry about the women in my life
Mm.
potentially being diagnosed with breast cancer. And so I think that's a personal motivation for me to keep going. But I think a lot of scientists are just incredibly curious and just want to find something new. And so that really motivates a lot of us to keep going as well. But I think a lot of people working in cancer research have had cancer impact their family and their friends, and they definitely have a really sort of personal motivation and drive just to keep going.
Yeah, look, and personally, I mean, most of my team know this, but my mum is a breast cancer survivor, and she got it incredibly young at the age of 50. Both my grandmothers and my maternal great grandmother died of breast cancer, and my mum, who is a doctor herself, always talks about the fact that she is around today because of research and the importance of research. So personally, thank you for what you do, because I know it's positively impacting thousands of people's lives as well.
And thank you for sharing that, Nikki.
So just to conclude, and thank you to all of you that have been on the call today. What do you have any last words for our audience here today, Kellie?
I would say just to be hopeful about the future of treatment and research for breast cancer. Um, if you saw the enthusiasm that I see every day amongst researchers, not just here, but in other institutes all around Australia, um, I think you would feel really optimistic about the future. And um, it's our research is just accelerating incredibly fast. So I think that there's a lot of hope for um, better managing the treatment of breast cancer patients and increasing their survival, and just keep supporting our research. And that's the only way that we're going to get there is if we can continue to get funding from government, but also from really generous and kind donors that fund Cure Cancer. So yeah, let's just all keep pushing towards our common goal of reducing breast cancer deaths.
Yeah, absolutely. And on behalf of all of us here and our team at Cure Cancer, thank you for the work you do. It's a pleasure to be able to fund your research. In fact, it's one of the highlights of my year when I get to phone the researchers to tell them that they're getting the funding. So please, I know there's a lot of challenges in what you do, but keep up the good work. We are very much appreciative of that. So thank you, Kellie.
Thank you,
Um,
Nikki.
no problem. And as we conclude our final lunch and learn of this year, I'm grateful to everyone who's made these sessions so engaging and meaningful. Thank you for being part of this. Your questions and discussions have helped bridge the gaps between cutting edge cancer research and our wider community. If you'd like to revisit any of our conversations, all the past sessions from this year are available through the link that Clarissa is going to pop into the chat now. They're also on our website. And to our dedicated donors, your generous support is driving discoveries in cancer treatment every single day. And this, as you've heard from Kelly, is inching us closer to life-saving breakthroughs. So because of you, research moves forward, clinical trials launch, and more patients receive life-changing treatment that continuously improves their quality of life. So as we look forward to a new year, we're inspired by your dedication to providing hope to all families that are affected by cancer everywhere. So thank you for being part of our community. Enjoy the Christmas break and the holiday season, and we very much look forward to seeing you next year. So until then, stay safe and Merry Christmas.